This has been a big year with lots of new important information. What we do as primary care clinicians is challenging. Seeing people all day long, keeping up with an ever-changing evidence base. It's also rewarding. We live in an amazing age where each year we're privileged to witness incredible advances in medicine. In recognition of that, I'd like to start with a quote from John F. Kennedy's inaugural address. And he said, "I do not believe that any of us would exchange places with any other people or any other generation. The energy, the faith, the devotion which we bring to this endeavor will light our country and all who serve it, and the glow from that fire can truly light the world." I'm Dr. Neil Skolnik, and today we're going to go over the highlights of guidelines that we covered over the last year. Let's start with asthma. The big change here in the GINA recommendations for asthma care have to do with the recognition that even patients with mild asthma can have severe exacerbations. Because of this, GINA now does not recommend that patients with mild asthma be treated with albuterol alone, but rather that an inhaled corticosteroid should be used whenever a short-acting beta-agonist is used. Patients with mild, that is step 1 asthma, now have 3 choices. They can be treated with low-dose ICS-formoterol as needed, which is not an FDA-approved approach, or as needed low-dose ICS-albuterol. Most conveniently, that would be budesonide-albuterol in 1 canister, which is now FDA approved. They can also choose to take an ICS daily, using either albuterol or ICS-SABA as needed with symptoms. The point here is to remember that people have less exacerbations when using an inhaled corticosteroid and ICS containing reliever medicine. In the United States, budesonide-albuterol is now FDA approved and per the GINA recommendations is preferred over albuterol alone as reliever or rescue therapy to decrease the risk of exacerbations across all severities of asthma. Next, let's point out the high points of the KDIGO 2024 Clinical Practice Guideline for the Evolution and Management of Chronic Kidney Disease. There has been nothing less than an explosion of knowledge around CKD over the past decade, and this has led to advances that are nothing short of phenomenal. We now have medicines that can slow the rate of decline in kidney function, help people avoid dialysis, and decrease the elevated risk for heart disease that people have when they have CKD. We should screen people at high risk of CKD, people with diabetes certainly, and consider screening for people with hypertension or cardiovascular disease. Screening should include both the serum creatinine and a urine albumin to creatinine ratio, a UACR. To substantially slow the rate of decline in kidney function and to decrease the elevated risk of cardiovascular outcomes, good blood pressure control with an ACE or an ARB is recommended, titrated to the highest or near highest approved dose. Also recommended are SGLT2 inhibitors. Here, the details of who should be prescribed an SGLT2 are important and have finally been clarified in these guidelines, and they are as follows. In patients with diabetes and an eGFR greater than or equal to 20, an SGLT2 inhibitor is recommended. In patients without diabetes, an SGLT2 inhibitor is recommended for those with an eGFR greater than or equal to 20 who also have a UACR greater than or equal to 200 milligrams per gram for patients regardless of albuminuria. If they have heart failure, they ought to be treated with an SGLT2. Patients with an eGFR 20 to 45 with a UACR less than 200, an SGLT2 is then also suggested. Notice this is a weaker recommendation for this group, suggested rather than recommended, as in the group I previously talked about. Once started, an SGLT2 inhibitor can be continued even if the eGFR falls below 20, and it can be continued until dialysis is initiated. For people with diabetes, a nonsteroidal MRA, that's finerenone, is suggested for adults with type 2 diabetes, an eGFR greater than 25, a normal serum potassium concentration, and persistent albuminuria greater than 30 milligrams per gram, despite other standard of care therapies. Note that the FLOW trial of the GLP-1 RA semaglutide in people with diabetes and CKD was published after the guidelines came out, so it's not clear where this would fit in. The FLOW trial did show a benefit on slowing progression of kidney disease and decreasing major cardiovascular events, as well as decreasing the risk of death from any cause. So it's important to know about. Next up, we're going to discuss prostate cancer screening. Now, here it's important to recognize that many organizations, the American Academy of Family Physicians, the American College of Physicians, and others, have their own recommendations, and they do not all align. So plenty of room for disclarity and confusion. What they all agree with is that PSA screening should be, when talked about, addressed as shared decision-making because the risk-benefit is not entirely clear. On one end of the spectrum of those recommendations is that of the American Academy of Family Physicians, which does not recommend routinely discussing PSA-based screening if the patient does not request it. Please refer to my original overview for other organizations' recommendations. Here, though, is what is particularly helpful in what the AUA guidelines recommend. First, for people with newly elevated PSA levels, clinicians should repeat the PSA in a few months before any further screening or diagnostic testing is done. And this is because 25 to 40% of elevated PSA levels are normal on retesting. Next, prostate cancer with PSA screening may begin for an average risk man at 45 to 50 years of age. For people at increased risk, the screening should begin younger, at age 40 to 45 years. But note here, the United States Preventive Service Task Force does not make a separate recommendation for high-risk individuals. Finally, after that first screen is done, the interval for PSA testing is every 2 to 4 years for men ages 50 to 69, and they recommend stopping screening around age 70. Next up, one of the most popular guidelines of the year was the Endocrine Society's guideline on vitamin D testing and treatment. This is something that I know a lot of people are interested in and have opinions about. First, all adults should get the Institute of Medicine's recommended amount of vitamin D, which is 600 IUs daily for those aged 50 to 70 and 800 IUs daily for those above 80 years of age. For adults 18 to 74 years of age who do not have prediabetes, the guidelines actually suggest against routinely testing for vitamin D deficiency and against routine supplementation. For adults with prediabetes, vitamin D supplementation is recommended to reduce the risk for progression from prediabetes to diabetes by approximately 10 to 15%. And for adults over 75, it is completely different. Because about 20% of older adults have low vitamin D levels, and because supplementation is safe, the guidelines suggest against testing for vitamin D, but recommend empiric vitamin D supplementation for all of those individuals. The guidelines don't specify a specific dose of vitamin D, but based on the doses used in trials of adults aged 75 or older, I'm going to suggest that a dose of 1,000 to 2,000 IUs daily is a reasonable choice for older adults. In the prediabetes trials, interestingly, a higher dose of vitamin D was studied, so a dose of 3,000 to 4,000 might make the most sense in that group. Let's now go on to migraines. The recommendations for first-line treatment of migraine headaches saw big changes this year. To put it simply, the American Headache Society now recommends CGRPs as first-line options for preventive therapy in people with migraine headaches. Many clinical studies have shown CGRP targeting therapies to be as effective or more effective than traditional first-line agents like tricyclics or beta blockers or topiramate at decreasing both the number of days per month of migraine headache and the severity of those headaches when they occur. CGRPs are well tolerated and they are safe. They are also effective in individuals who have failed multiple other first-line therapies, so they can be used as first-line therapy, and they can be used in patients with difficult to treat migraines. Monoclonal antibody CGRPs are easy to use, and they come as a monthly subcutaneous injection. For a quick reference, see the table that I put together with generic and brand names, as well as dosing and monthly cost. My suggestion is pick one CGRP, get to know it. It's a useful therapy that patients appreciate. Next up, and hold on to your seats on this one, we're going to talk about the revised criteria for the diagnosis and staging of Alzheimer's disease from the Alzheimer's Association work group. Again, talk about big changes in the way that we think about a disease and approach a disease. Here it is. Until recently, Alzheimer's disease was the diagnosis that remained after we ruled out all other causes of dementia with our blood tests and imaging. Moving forward, Alzheimer's disease will be ruled in using blood-based biomarkers. The key principle that this guideline lays out is that Alzheimer's disease is defined by its biology, that is, by the neuropathologic changes in the brain characterized by deposition of amyloid and tau protein. A recent paper in JAMA showed that the blood-based biomarkers using a ratio of 2 tau proteins and 2 amyloid proteins were accurate in identifying Alzheimer's disease more than 90% of the time. We are nowhere near that accurate in identifying Alzheimer's disease clinically. Once there is regulatory approval of the blood biomarkers, which is coming soon, our whole approach to the diagnosis of the cause of dementia will change. What will that look like? Well, in addition to ordering an MRI to look for structural lesions and evidence of multi-infarct dementia and ordering labs to rule out other causes of dementia, we will be ordering blood tests to see if the person in front of us who might have mild cognitive impairment or dementia actually has Alzheimer's disease. Next up, I want to talk about ApoB and the expert clinical consensus from the National Lipid Association that gives us much needed guidance here. ApoB is the main protein that's found on all atherogenic lipoproteins, and it predicts cardiovascular risk actually more accurately than does LDL cholesterol. While it's often correlated with LDL cholesterol, certainly at a population level, in individuals it can be discordant. And this is actually when it's most useful. And that brings us to the two circumstances where ApoB is helpful, and these circumstances are worth remembering. First, in patients who have borderline atherosclerotic disease risk on our ASCVD calculator, if a patient doesn't want to start a statin, ApoB can be ordered and then used to further risk stratify. If ApoB suggests the person's at low risk, then that's fine. Withhold the statin. If ApoB suggests the person is at higher risk, then that would favor starting statin therapy, and that's important to discuss with patients. Turns out that this becomes important in certain common clinical conditions, including obesity and those with insulin resistance, metabolic syndrome, which can lead to smaller cholesterol-depleted LDL particles that result in lower LDL cholesterol, but falsely low with regard to risk. In these cases, elevated ApoB levels may drive the decision to treat with a statin. The other circumstance, in patients who are already treated with statins, in whom we're deciding whether or not further treatment intensification is warranted. Here, if the LDL goal is met, but ApoB is still above their threshold, then treatment intensification may be considered. Here, take a look at the table in the original article for specific levels. Remember, and this is important, this guideline does not suggest that the standard of care should be measuring ApoB in all patients, but rather that ApoB can provide important and helpful information for decision-making for specific patients, and that's most likely to be helpful in patients who have metabolic syndrome, diabetes, visceral adiposity, and insulin resistance. Finally, let's talk about a guideline on urinary tract infections, that is UTIs, issued by the WICI Guidelines group that was published in JAMA Open Network. First, always put the results of a urinalysis into clinical perspective, as it, like many tests, is an imperfect test. The sensitivity of leukocyte esterase is only about 80%, with even lower specificity. The sensitivity of nitrite testing on urinalysis is actually below 50%, meaning the test is negative more than half the time when someone actually has a UTI. So don't withhold treatment solely because the nitrite test is negative. Now, recognize that the specificity of urine nitrite is greater than 90%. So if it's positive, then the person very likely has bacteria in their urine. For healthy people with simple bladder infections, urine cultures are not necessary. Treat it empirically. For uncomplicated cystitis, first-line treatment is nitrofurantoin for 5 days. Other first-line agents include trimethoprim sulfa for 3 days, phosphomycin as a single dose, or a beta-lactam, often a cephalosporin. It's important to distinguish uncomplicated UTI from pyelonephritis, because pyelonephritis requires a decision about inpatient versus outpatient treatment, and that decision is made based on our clinical judgment of how sick someone is. For pyelonephritis, always get a urine culture. For outpatient treatment of pyelo, the guidelines suggest both trimethoprim sulfa and a first-generation cephalosporin are reasonable first-line agents. Other generation cephalosporins are also probably reasonable. With fluoroquinolones are also reasonable choices as well. Ceftriaxone is a good inpatient choice. Now, for women with recurrent UTIs, remember there's things we can do. Consider doing something to decrease that rate of recurrence. That can be increasing water intake if someone isn't drinking a lot of fluids, or even encouraging cranberry juice, which turns out to have a reasonable evidence base to decrease recurrence. Methamine hippurate is FDA approved for prevention of UTIs. It works by releasing formaldehyde in the urine, and that formaldehyde is bacteriostatic. You can also use antibiotic prophylaxis, either postcoital or daily administration of trimethoprim sulfa or nitrofurantoin are both effective, with a decrease in UTI recurrence rate of approximately 85%. If a woman is postmenopausal, don't forget, topical vaginal estrogen cream can lead to a 50 to 90% reduction in the incidence of recurrent UTIs. There have been many important changes and updates over the past year that further allows us to do just amazing things for our patients. Medicine is truly one of mankind's greatest achievements, harnessing science to fight disease, improve health, and promote well-being. Let me come back to the inaugural address of John F. Kennedy that I mentioned earlier. Here, in concluding that address, he said, and I'll quote, "Let us go forth to lead the land we love, asking his blessings and his help, but knowing here on earth, God's work must truly be our own." Let me take this opportunity to say Godspeed. Have a happy and healthy new year, and may we all continue to do the important work that we all do each day to help our fellow man with joy, with satisfaction, and with good spirit. I'm interested in any thoughts you may have. Please leave them in the comments section. For Medscape, I'm Dr. Neil Skolnik.